Perfect. Well, welcome everyone. Good morning on this beautiful Tuesday. Again, I've said this before, but I really am excited to see all of you here virtually and in person. And I also want to just be, giving thanks to Dr. Yamada and to Kim and to Rafael and Cynthia and to everyone that really just came together for this event. It's definitely been the work since last semester, so we're really excited to give you the information. And I think it's really important to talk about this topic at this time. I know that these are concerns that not just us students have, but professionals, LCSWs, professors, faculty. So this really came out from the needs of the community. And so I really hope that you get what you get something out of this after we're done here. So before we get started, I'm going to just go over some very brief community guidelines, as well as some upcoming events. And then Kim will, if you'd like to do the introductions and kind of just get us started after that. And this is going to be kind of an organic conversation as well. So for the community guidelines, this session is designated to foster mutual respect, curiosity, and civil discourse. So our goal is essentially to provide practical tools for navigating client work in divisive times. And given the sensitivity of these discussions, moderators like myself and Kim and Anne Marie will guide the conversation to maintain focus on that purpose. And so to create that brave and safe space, we just ask you to commit to giving your full attention to the person speaking, making space for diverse perspectives, experiences, and contributions, engaging with curiosity and compassion by calling in rather than calling out, speaking from personal experience using I statements rather than broad generalizations, practicing self-reflection and prioritizing self-care, and recognizing that everyone, including our panelists, they are all lifelong learners, and sometimes we don't have all the answers. So with that, I will also share a couple events coming up with NASW, and I will put the flyers in the chat as well. But just for your information, we do have an info session with NASW coming up next Tuesday, February 11th at 11 a.m. to 12:30 p.m. hybrid. And we'll be talking about everything NASW as well as lobby days. We also have a Veterans Care Package donation going on with the Black Student Social Work Caucus. So if you're interested in donating for Veterans Care Packages, I will also put that in the chat as well. And then I'll also put other things in there for your reference, such as a sign-up sheet if you're interested in joining, as well as all of our social media accounts. So with that, I'll turn it over to Kim and to our wonderful panelists. Thank you so much for coming.
Hello, everyone. Before we move on, I just want to make sure everybody feels comfortable with the guidelines community agreement that Jason shared with us. If there's any questions or concerns about it, we want to make sure we address them right off the bat. If there's anything in the chat, Professor Yamada, can you let me know? Because I'm not looking at the chat at all. Welcome, everybody. It's really nice to be in this shared space with you and with a common curiosity about how we kind of navigate these challenging times with clients, and as well perhaps even in our placement settings or places of employment. We're really fortunate to have two amazing panelists today that I am fortunate enough to call my colleagues and who I learn from every day. I'm going to have each of them share a little bit more about themselves, but for those who don't know them, we're fortunate to have Professor Rafael Angulo. I've been here almost 21 years, and he was here before me, so we're both a little bit of dinosaurs here. And Professor Cynthia Juarez, who will be sharing her wonderful clinical experience with us as well. Would you both be willing to share a little bit more about yourselves?
Okay. Okay, again, my name is Cynthia Juarez. I am assistant professor, teaching professor in the practicum department. A little bit about myself. I've actually, I think it's been a year. February is going to be a year that I've been here as faculty. Prior to coming to USC, I was working with the Department of Mental Health for 11.5 years. So I spent about 5 years as a mental health clinical supervisor, supervising clinicians in the CalWorks department with adults and also the Children and Family Services program. And we were funded through the Department of Mental Health. And so I was able to see a lot of different shifts during COVID, being able to service the community in person and then shifting to the virtual world. And then prior to that, I was a PSW working with CalWorks adults. And then before that, I did like family preservation and then just community mental health with families and children. So that's where most of my experience comes from. And I'm very happy to be here.
Thank you.
My name is Rafael Angulo. Now in my 23rd year here at USC, which has been a blessing in many ways. I have a private practice in which I see my clients. I work with a lot of fathers and men, especially fathers whose children have been taken out of their homes within the umbrella of public child welfare, and working with men sort of really beginning to sort of understand their own sort of masculinity and issues of depression and anxiety and various other mental illnesses. I did work with DCFS for about 12 years, and I teach a documentary filmmaking course for the past 20 years. And I feel really honored to be invited by Professor Goodman to this engagement.
Thank you both for being here. We appreciate it. I'm Kim Goodman. I am an associate professor of social work practicum education. And if anybody's taken the VFP or social work 510, you've seen some of my recordings or had me in class. So welcome. And I'm the student wellness coordinator. So we're glad you're here and we're glad to have our panelists. We did collect some questions and came up with some questions for our panelists. At different points, we'll be breaking throughout and leave time for questions and answers at the end. But at different points, we'll pause and say, is there any comments or questions that people have? Because we really hope this is a interactive workshop, because we really want you to leave with your questions answered. But to get us started, I'd love to start by asking our panelists, has there ever been a time that, sorry, the camera's over here. I want to look at you all and I want to look over here. Has there ever been a time that your personal or professional values conflicted with those of your client? And how did you manage that by staying authentic to yourself, but also being client-centered and being in a space with your client? So that's a broad beginning, but perhaps you could speak to that. We'd appreciate it.
So I took some time to think about this question. And this experience follows me and I use it a lot and I remember it because I was a MSW intern and I came to USC also. And I was an MSW intern. I was very, very green, but I always have known that the clinical work is my work. And that's what I've always wanted to do. And so I've chosen to work in certain communities that are close to me. And so my internship was in the Pico Union area. And in that area, there's so many different communities coming together. There's some parts of it, where I'll just start with the client. I had a 10-year-old client. He came to treatment because we believed that there was some gang involvement or someone, I think the parent believed that there was some gang involvement. He had a cancer diagnosis when he was younger. And they assigned him to me. And, we were trying to navigate, like, is he part of a gang? And that became kind of the focus. And of course, he's not going to say. He's 10 years old. He knows the risk if he does say that. And so we just really got along well. We did art, we did so many things together, and he really trusted me. And if anybody's familiar with the Pico Union community, there's a lot of ethnic groups that are within the community. And so everyone's, there's a lot of lack of resources and just immigrant communities trying to live together. And I don't remember how long I had been seeing this client, but he made a comment. And so I'm from I have a Salvadoran background, and his family's from Mexico. And so there's a long history behind that. I'm not gonna go into it, but there's been conflict, and now things are they're different. But since I was a child, I had always heard comments. And so in our treatment, I don't remember what we were discussing, but he stated, "Oh, I hate Salvadorans," right? And I sat there, and of course you're like, oh, you get that physical response of like, what do I do with this? What do I say to him? Does he doesn't know who I am? He all these questions just come up. And so even though I was really green, I felt like it was an opportunity, and I felt like we had a good enough relationship to where, I mean, of course I had to really think about it, how I was going to address it with him. And I thought that it was an opportunity, because I could tell that he was really connected with me. And even for him to say that, I think that he trusted me, right? And so I asked him a little bit more, and I said, tell me more about that. Tell me your thoughts about that and how that came to be. And so he started discussing this with me. And so I decided to let him know. I said, what about if I told you that my background is from El Salvador? And, he had the shocked look in his eyes, and he didn't really know what to say. And I said, just, it's okay. Like, I thought that he was 10, but I told him, I thought that this was a good opportunity for me to let you know who I am, because I could see that you come to treatment every single week, you trust me, and we have a really good relationship, right? And I said, do you think I'm those things as well? And he said, no, I don't. And so we just had a conversation about our cultures and the possibility that this other culture could be other things other than what he was told. And it was an opportunity, and I took it, and luckily he took it in, and we were able to have a conversation about it, and he kept coming to treatment. So that's my example that I have for that. Thank you.
Yeah, I mean, what a beautiful example of self-disclosure as a tool for breaking down that cognitive distortion that I may have had regarding the Salvadoran population. For me, the way that I frame it just in my mind, and it's sort of like a first principle, and that's the principle of awe, A-W-E. That when somebody who is in front of me is, sharing information that for me creates a deep sort of anxiety and tension, I think what I've learned to do, and this is not anything that you just push a button and be in awe, but I've just come to this realization with all the clients that I've worked with and the people that I've interacted with, the complexity, what it means to be fully human, along with the traumas and the experiences. And so this awe, in the same way that we're awed by the universe, when we look out into the stars and see galaxies and a wide variety of things in the flora and the fauna of creation, you're just awed by its complexity. And I think the same way when somebody who is perhaps right of center, which is different from my sort of progressive leanings, when somebody is perhaps anti-immigrant, I have to say that I don't get as anxious or angry now, perhaps because I've grown, I'm mature. I'm not exactly certain what the reason is, but I'm awed by how they've come to who they are in terms of their thoughts regarding, throw these people out. That's a mortal sin. They come from maybe a Catholic background in terms of being trans, or and so I'm just awed by their complexity, and I'm really, I'm trying to lean in and what we call sort of thinning slicely. Like I don't want to go deep into it and start to even pose questions like, why are you this? Because I don't think it works. I think I'm just, tell me a little bit more about how you come to draw these sort of conclusions. I'm really interested. And sometimes I'll be very sort of relational. I said, I'm wondering if we can just sit with each other for a bit and help me understand where you're coming from. That to me, that relational stance, I think is so important when we begin to confront, clients who are very different from us. And so I rather lean in than lean out. And I think that really begins with the first principle of awe of the person that's in front of me. So that's just because I think my nature is more spiritual. I'm just really wanting to sort of understanding the complexity of who is in front of me.
So a few points that I take from that perhaps resonated with me, and I'm not sure if I'm interpreting it as intended, but a certain level of curiosity versus a quick, where we often have like the cancel culture, like we have different beliefs, but certain number, not just like diving into it, but just curiosity for who the person is. And also, I heard relational, so a little bit of trust in the relationship that perhaps has been built if you've had opportunity to do that, is what I take away a little bit from what both of you have said. Is that accurate? Jason, do you want to ask the next question?
Yeah, actually, to follow up on that as well, and thank you again for sharing, Rafael and Cynthia. I feel like a lot of us students and also perhaps professionals are really in this space where if our client says something offensive, like not just about our race, but maybe about a community that we have so much care for, like the trans community and the LGBTQ plus community in general, immigrants, and especially during this time, and looking at, how divided our community can be in politics and media, I just have this question of what advice would you have specifically for this difficult time? And maybe you have some examples of learning, like looking for those like learning opportunities from our clients rather than continuing that division. I think you kind of mentioned it already, but for things that really kind of get us like boiling, and how do we remain calm, and how do we continue the therapeutic relationship? If you could share anything on that as well.
Because my background is in sort of relational psychodynamic work, where we begin to reflect on things such as the unconscious, early childhood attachments, beginning to really reflect on some of those developmental timelines from birth until adolescence. I think the thing that sort of I connect with is sort of this concept of drop, stop, and stay, meaning when there's something really powerful that's happening in the moment that perhaps is bothersome to me, or at the very least, I notice in them perhaps this real felt sense of this disregard for the other. I want to sort of drop, stop, and stay. I want to stay with what's happening to you at the moment. Tell me what's going on right now. And I'll allow the silence just to be present. I don't think I need to fill it up. And I think clients appreciate that there's a certain sort of listening ear that's not only honoring and respecting them, but also wanting to stay with a certain unconditional regard. I know that they're there most likely because of depression, anxiety, bipolar, and I want to sort of really continue to hone in on what the presenting problems are. Obviously, there are other issues as well. But for me, the clinical concept of sort of drop, stopping, and staying is sort of a motto that I keep always in the back of my mind as something that's really important. Allow us in this sacred space to explore your thoughts and feelings regarding particular disenfranchised group, for example. You know, and once again, it's holding that complexity. And we tend to put other people in very binary kind of ways because we look, for example, at the DSM-5 TR. This is what you are based on the symptomatologies. And this is how we're going to categorize you. And yet, you know, we don't always use the DSM-5 as our treatment plan. That is to say, because if you have major depression, that this is going to be the treatment, because there's so many other aspects of who the human is in terms of issues regarding poverty, class, sort of this history of racism. And so to me, that's just important to be able to, like I said, to drop, stop, and stay as a clinical sort of engagement with the client.
Yeah, I was thinking, when you said the stop, and I was thinking, more from also the clinician. It's like you automatically, some topics you just want to just say something. But what I've learned is that you really have to stop and really, you know, it's all these things that you're doing at once. And that's what a social worker is, right? That you're scanning your own body. You're in tune with yourself and your thoughts, and you're going to stop and really think about how are you going to respond to the client, right? Because ultimately you're not there for yourself. You're there in service to others. And so, but you know, there's work that needs to be done on your part as a clinician, whether it's like actively being in supervision and actively talking about these triggers that you have, and asking for support as to how do you go back into those sessions. And when you are in those sessions, it's really practicing, like Professor Angulo said, is what are you there for, right? What is it that the client is bringing into the room, and how can you use it either to assist them, support them, further explore, and also depending on where you are in the relationship with them, you know, it could take you to further discussion on so many different paths, to exploring, you know, their thoughts about whatever that statement is. So I think it's supervision is so important, really getting the support that you need to be able to show up for clients and for yourself.
So if I could summarize with some perhaps tips that came out of what you both said, I was taking notes as you were speaking. But please add if I've missed any. One is first knowing your purpose, right? Like we're there for a reason, and that's to be in service of the clients, however you define that, individual families, communities that we serve. So knowing what our purpose is, which includes always being, in my opinion, client-centered. Remembering that we're there for the best interests of the person sitting in front of us. You also spoke to really self-awareness. That's the stop, I think, and self-regulation. Being able to stop, notice what's coming up for you. That's why we do those RLTs you love so much. Notice what's coming up for you, and being able to like sit in that discomfort for a moment to decide what maybe the next best course of action might be that would be in the client's best interest. To be able to sometimes maybe sit in silence, I heard you speak to. And then also, this is a DBT term, but like cope ahead, meaning you anticipate there might be some of this coming up with a client, or even if there's not a specific client, to perhaps seek support, consultation, and supervision, so you can think about how would I dance with this if this were to come up in an interaction. So that's some of what I heard and what you've shared so far. Is there any other tips, if you will, so that the students can and participants can maybe walk away with some concrete tips in mind? Anything else you want to add to that?
I think the one thing that I would add, I don't necessarily think that we need to always bring up topics that come up for us at the moment, because we're holding, if you will, this new information, and we can just sort of keep it in the back of our mind. And so let me just put this in reserve, if you will, and bring it back when I think is necessary, you know, and without any sense of judgment. Well, that's an interesting statement that they just brought up. And let me just hold that, because it's not maybe the right time once again, I keep thinking of this lean in, but slightly thin. I don't want to go all out, just a little bit by little bit, and that's just the way that I work in terms of sort of moment to moment tracking. I'm just aware of what's happening at this particular moment, but I don't necessarily think we can hold something and bring it back later.
I wonder if we could jump in now with some questions before we get too farther away from the current topic.
Yeah, so first, I think we have some questions in the chat, but I know some people have been waiting for their hands raised. I believe there was Tatavik. Did you still have a question or did you put your hand down?
Yes, so my question was, what happens if you are the carrier of the mental shortcuts? So I'll give you a little example of myself. I'm from Armenia, and my grandparents were victims of genocide. And lately, I keep thinking about how would I behave if a Turkish person comes to me for help. I had a small experience when someone came to me and we were talking nicely, chatting in a library. And then when she told me she was from Turkey, I had this fight or flight response. I was just all tensed and my breathing got very intense and I just wanted to leave the space. What happens if you are a clinician and you're in that situation?
Yeah, that's really a remarkable example, especially because there's such history to it. And I've known sort of numerous examples that are similar after Hamas on October 7th massacred thousands of Jews in Israel. Many of my students who are getting their LCSW degree mentioned the fact that they were recognized as being Jewish as therapists, and that their clients were either not responding well to the way Netanyahu has responded. And there was a lot going on in terms of these Jewish students who were having to confront the reality that other people may see this differently, and having visceral reactions to, like, don't you not see the heinousness of what Hamas did on October 7th? And sometimes there would even be sort of these sort of tender argument, but that began to escalate. The other person would say, can't you see how Netanyahu's responding to what is going on, disproportionate to what occurred? And I think one of the things that really comes up for me as you bring up this remarkable example of sort of the Armenian genocide, and what is it that you have this almost default response to somebody who is Turkish. And we recognize that, Turkey has, pretty much set this aside and not taken it seriously, and for many years, and I think that's still the case, that the United States has not recognized the Armenian genocide from a sort of national level. So there's a lot of politics and there's a lot of history involved. But I return back to the comment that I think that I made is that there's a certain element of being able to sort of recognize that somebody who is Turkish has their beliefs because of X, Y, or Z. It's been inculcated. They've heard it from their Turkish parents over and over and over again. And perhaps we also need to look at ourselves, that as Armenians, or whatever other culture we want to talk about, we have heard the same thing about the other. So there is a sense of the horror of the other. We create, if you will, something so horrific about the person who's in front of us because of these messages that have been inculcated to us, that we create almost a monster, if you will. You know, the sort of play of you know, zombies and the zombie apocalypse and the sort of very binary way of understanding the other person, that we want to just shoot them. And I think that there's this tendency of us wanting to sort of psychologically other them. And my sort of advice to, you know, my students who are getting their LCSW degree, is be able to sort of look back and say, what is it about you othering somebody? What is it about you learning that somehow the other was so bad? And so it really requires a lot of self-reflection, a lot of deep introspection. And so it's not easy. I'm not even asking you to push a button. I'm asking you to reflect about those experiences. For me, it would be somebody who is very anti-immigrant. I have to respond to that in a mature sort of way. And you know, I think just the capacity of us to be able to recognize how we other people, this, if you will, this creation of a monster in front of us, that our mind sort of almost by default plays into it. So it's more of a reflection than anything else, that I just wanted to share.
Yeah. I was just thinking about liberation psychology just because I'm reading it now, but well, actually, no, it's actually a FOPE that talks about being able to learn from the client. Like we're not just, it's not that they're just learning from us, or it's also that we're gaining something from them as well. So I feel like it's an opportunity. But ultimately, you know, if you feel triggered, I mean, again, I always go back to supervision. You know, that's the place where you discuss your triggers and how you're going to manage that, if you're going to be able to manage that, because then you also have to think, will you be of service to that client if you're not able to self-regulate yourself, if you're not able to be able to sit with the client and just be there for what they're there for, right? So I think really paying attention to your own treatment, you know, have you received your own treatment, trauma treatment? And how are you using supervision? Are you being supported in supervision? And if you still feel like you can't go into the room with that client, I think there needs to be consultation about what else needs to be done. Are you the appropriate therapist for that client? Is there someone else that maybe, whatever it is, that could service that client, you know, yes, that maybe won't have the same triggers and will be able to sit with the client and, you know, provide whatever it is that they're seeking.
Yeah, thank you. I'm hearing a lot of just making sure that you protect yourself essentially, and that you're able to, in a way, have those different outlets and right to make sure that you understand how you feel, regulate yourself, but as well as be present for the client during that time. We have some other follow-up questions as well regarding a little bit of what you've said, and I think if it's okay to address some of the questions in the chats that's been waiting a little bit on top of that. Is that okay, Kim? Or are there any questions? Okay. Okay. So some people have been are in areas that could be considered more conservative. And there's that, concern that how do we create a safe space without depending too heavily on self-disclosure, as well as perhaps there's clients that use this space to continue to push boundaries or be resistant and avoid any emotional engagement. Perhaps a therapist is trying to practice what you're saying, but the client is still not responding. So those two are two questions, if you have any answers to those.
I'll start with, I stopped using the word resistance with clients to identify what's happening with them. I tend to look more at what's the interaction, what's happening in the session, or why is it that I'm feeling like the client isn't responding, or if I had clinicians that would come in and say, oh, the client's being resistant, I'm like, well, what does that mean? What does that look like? I think we tend to use that word because maybe we're feeling a certain way about the client. So I just wanted to say that part. But also, you know, I think there comes a time where, yes, we're in service to others. But also if you're working harder than the client and you're getting upset, then you're more invested than the client is. And always having to go back to what is the purpose of the session? What are they there for? Why are they there for? Wait, I said it right the first time. What are they there for? You know, always going back to that. And so I don't know if I'm answering correctly, but I think just really focusing on also, you know, I always go back to supervision. It's, you know, if you feel like something isn't working, then what needs to be changed? Is it the clinician that needs to be changed? Does the client feel the same way about the clinician that something isn't working? So that's the discussion that needs to be said. I talk about transparency, and I think it's important in sessions with clients to talk about how is it going for them. If you feel that it's not working for you or that the client isn't responding, then what is the client thinking? Do they think that it's working? Maybe they feel the same way. So then that's something that needs to be discussed as to whether you are the best clinician to be with that client.
Yeah, I mean, this is very much based on feedback informed treatment, where the research is fairly clear. I mean, just imagine that you're with a doctor or a psychiatrist and has given you a certain, you know, dosage, 25 milligrams, and the doctor never poses the question, how are you now that we've increased it from 25 to 50 milligrams a month later? They never asks, how are you responding to it? And literally, there are so many social workers and clinicians who never pose the question, how are we doing? How is treatment going? This capacity to be able to really get feedback from our clients, we would consider that anathema if our doctors after a surgery, you know, said nothing, you know, in terms of asking us about how are we, you know, responding to this surgery. And so, you know, I do it after every session, like about 3 minutes prior to a session ending. How are you and I doing? You know, and are we getting closer to working on what it is that you need to do? And so I think the capacity of always asking for feedback, especially the relational quality to it. How are you and I doing? Are we connecting? And if not, if there are ruptures in the alliance, then it's worth talking about, you know? And so for me, you know, being able to say, you know what, can I just stop for a second? I'm noticing that there's a disconnect between you and I. Are we okay? You know, no, you know, you brought up, you know, I talked about this person I'm really interested in, and I don't know, you just kind of blew it off. You know, okay, that's a rupture, and I want to bring it back. You know, what is it that I said? I apologize, you know. So there's a saying that therapist disclosure begets client disclosure. And by disclosure, I mean what's going on in the session, not necessarily what's going on in my life. And, you know, I'm getting this and this is happening in my own relationship. No. I think it's really important for us to recognize that I want to bring up what comes up for me in the session between my client and I.
Yeah, it's use of self, right? It's like how you could use yourself as like, well, if I'm feeling this way when you're saying these things, you know, you said that your mom responds a certain way, just being able to use what's in the room and have them reflect, is this what happens outside of the session, right? With your friends or.
Just out of curiosity, are we still teaching feedback informed treatment in the first year? Because I haven't taught the first year seminar. No,
No,
we're not.
no.
So it might be worth just referencing that so people can further look into it. Would you agree? Because I
Yeah.
think do you want to speak to it? Because you're the one who had brought it into our class.
No, I mean, in essence, feedback informed treatment, which is a SAMHSA qualified therapeutic treatment, is just basically saying, almost like if you were using a graph, how are we, meaning the relationship, and how are you, meaning your development and growth? And that's measured through a graph chart. Now, you can do it very informally, and really what they call outcome rating scale, in terms of what the and session rating scale. How is a session between you and I? And it's constantly it's a feedback loop, constantly giving you information regarding how myself and my client are doing. It's really powerful when it's used correctly, and it keeps you accountable. It keeps you accountable. And I think that's what's more like, because we're afraid to ask the question, how are you and I doing? We're afraid that you suck,
Yeah.
you know?
And that's Scott Miller, correct?
Scott Miller,
So if people
correct,
wanted
yeah.
to look it up, it's feedback informed treatment, and it's Scott Miller. He's got some really good videos out about it. I remember. Jason, do you want to?
Yes. So again, thank you so much for answering those questions. We also do have some very patient people waiting, raising their hands. If it's okay to bring up, I feel like our conversation is also going based on our outline. So I feel like it's okay to kind of, or just continue with questions. So Ladoris, you've been holding your hand up for a while. What's your question?
Hi, everybody. Okay, I had a situation. This was in a case management capacity because I haven't graduated yet. Well, I took a client shopping for our monthly shopping, and she disclosed to me that when she leaves the store, she's gonna go smoke some crack. And I was taken aback. I didn't know, it was startling. And I was just wondering what a person could do this in a therapy session. So what is a good response, or any feedback would be great.
We might not have all the answers.
Yeah, well, is there an agency policy in regards to disclosure of that information? I mean, is this person being drug tested on a regular basis? I'm just curious, just so that I can at least understand a little bit of the context that you're in.
No, there's no random drug testing or what have you, but we are providing benefits. And I think you know what, now that I'm saying this, it might have brought up a bias for me. Because if we're providing these benefits for them to, as how it come across to me, supporting a habit. Because why would a person disclose that? I'm taking them shopping for groceries, necessity type things, had nothing to do with, I'm not connected with her drug related, period. But for whatever reason, she decided to disclose that. So for me personally, if I'm providing you with benefits and you're telling me you're actively using substances, that would be, be difficult to support that in that capacity.
But you prefaced it by saying that it was a therapeutic moment. I thought I heard you say that. Is that true? Like what is
No, I'm a case manager at the time.
okay.
And I have to take my clients shopping. I pay rent, I buy groceries, things of that nature. And that was the first time I ever had a client state that. She was like, yeah, when I leave here, I'm going to do this. And I didn't know how to respond.
I've had, I don't know, well, they're not exactly that. I'm trying to think about the experiences that I've had. And I think that clinically now, I mean, I've had people say like, oh, I use meth, you know, and it's in a clinical setting. And so my first thing always goes to, well, were there children present? Like what happened? And, you know, I always go to safety first. But I also think about what's the purpose of this person telling me this? Right? And I go all these different, you know, is it because they want my help? Is it because they want to talk more about it? Is it because they just want to tell me they're going to go have fun? Or is it deeper than that, that they don't know how to stop? And because I think in a clinical setting, they know I'm a mandated reporter. Because I tell them from the beginning, and even when they say, I want to tell you something, I tell them, I remind them, remember, I'm a mandated reporter, there's certain things, and they still will tell me. So for me, I take it as, okay, this is something that they really want to talk about, and how can I be of support to them? How can I further explore it, whether it's because they want more treatment? Of course, your situation was different. But for instance, this program that I'm referring to, it's a CalWorks program. And so some of these people had jobs that paid them under the table. You know, some of these people were using the money that they were getting, obviously, to get meth or whatever it is. But my place there wasn't to monitor what they were spending their money on. That was actually, there was a time when social workers were reporting anonymously clients that were, you know, working under the table and still getting assistance. But by the time I came around, they made it to where you could not report any of that. That was none of our business. That's not what we were there for. We were there to provide a service, which was removing barriers for them to return back to employment. It was not. And if they wanted assistance with harm reduction or substance abuse, then we were there to provide that service. But I think it's really about, again, you know, your own bias, like you identified, right? And where do you go talk about that, right? Do you have that supervision to go talk about how your own biases are affecting how you're gonna next support that client? Or, you know, are you gonna still do that for that client? That's a requirement of your job. Are you still gonna do it for her, even though she said she's smoking crack? Right, so I think it's really, again, really reflecting on, again, your own biases, and then how is it affecting your work? Or is it relevant? How can you, that disclosure, you know, even asking, you know, I mean, in a case like maybe you would use different language, but I'm curious, you know, why would you tell me that? You know, or if you have that kind of relationship, you know, now I'm kind of concerned, you know, that you're going to do this because you've been talking about that, you know, you're working on that. I think it depends on the relationship and just.
Well, but see,
Yeah,
here's the thing, we were checking out at the register.
Yeah, and I think like in certain positions, because we get so involved in clients' lives that they start trusting us, right? And they start kind of testing that boundary of like, well, I kind of want to be more friends with you, so I'm going to give you this information. And then we have to figure out, what are we going to do with the information? Do we do something with it, or do we just leave it as it is?
Thank you.
Thank you.
I just want to acknowledge that we have about 8 to 10 minutes left.
Mhm.
I don't know if there's questions in the room or questions in the chat that we want to make sure we get to, or if we want to pose 1 or 2 last questions from our list. Are there any other questions right now?
There are a couple. I think there's only like about 2 that I'm kind of like summarizing together. Are there any questions on your side though, Kim?
No, we're good.
Yeah.
We just mentioned that one of the things I'm hearing is potentially careful need for boundary discussions and setting, because relationships are super important, but at some point the relationship can be seen potentially in different ways, and how do you manage that? Because if it does become something that the person perceives as a changed relationship to a friendship relationship, it might invite more of the kinds of things that we're discussing and raising. And I don't know. the comment, I guess.
A great comment. I think that's an important part of the conversation is how do we set healthy boundaries with clients so that it remains a safe space for everyone. I think that's an important part of the conversation.
Yeah, I think boundaries is a really good point. It made me think of like having an adult child, like when my 20-year-old was like saying that he and his friends were gonna go drink. And it's like, okay, we need to have boundaries, but not, it feels like kind of like that relationship of, I guess it's 21. But anyways, just like saying that you have to have boundaries.
Agreed. Boundaries in the clinical setting and outside, right?
Yes,
In
yes.
many different settings, the importance of it.
Awesome. Thank you so much. So I guess just the last two questions, and please let me know. I know that some hands were up and I don't want to have missed anyone. If you still have a question, just leave your hand up and then maybe we can get to it as well. But the two questions that I found really kind of coming up was, one, is it our responsibility to educate our clients about, what is respectful behavior or respectful, well, I feel like behavior is kind of harsh, but more like how to just be respectful in terms of these divisive times. And then the second question is when and where is that fine line between I'm not the best provider for this client, and I think it's best to perhaps recommend someone else who's, a better expert in this case. Yeah, what were your thoughts on those two?
Can I just add to that also, and how do you do that without causing harm?
Yes, exactly. Yeah, right.
Yeah, I mean, you're posing the question in regards to, do social workers have a moral and ethical obligation to correct somebody? And, that is to say, for an internalized thought about a marginalized grouping of people, or regarding physical abuse that they're manifesting towards their children. I'm just trying to sort of delineate what can be some of those sort of differences. When we talk about elder abuse and child abuse, yeah, we do engage in sort of the ethical and moral act of protecting on behalf of the safety of someone who is elderly, someone who is young. So we'll set that aside. But what about, the use of the N-word? What about the use of, those wetbacks? What about, really creating a humiliating sort of shaming commentary regarding trans youth? And do we have a moral obligation to respond to that? I think it's very sort of particular, but I would only go so far as to say, I want to question as opposed to point my finger and say, stop that, don't do that. I'm just curious, you use the word "and" or "wetback" or whatever. Where does that come from? I'm just curious. Try to be as gentle and tender about it as you possibly can. Because I think the moment you begin to sort of flush it out as some sort of moral depravity, then the client begins to feel as if I'm no good, maybe. I thought I trusted you. And so would I like that person to change? Of course I would. But I don't think that's necessarily in my place. Listen, talk to a preacher, a rabbi, a priest for those moral questions. I'm thinking about the psychological, about what's going on with you and how did you begin to frame the other in such a way. So I would be more sort of in a gentle, tender sort of way reflect on that with the client.
I agree. I mean, I think also, you know, I don't have anything to say about that because I completely agree. But once it gets to the point where you feel that you can't keep going back into the room with the client, I mean, that's when, again, you go to supervision and you discuss what are the other options, right? What are the other options? I mean, we've had situations where clients call us and they're cursing us out and, you know, and we, you know, I learned to directly say, I'm not going to be able to help you if you're speaking to me in that manner. You know, please change your tone of voice and we can continue. So, I mean, there are limits that you can, I mean, every situation is going to be different. But, you know, don't feel like you have to be in there and you're just like feeling so awful and just feel miserable at your job. Like, you also have to take care of yourself because that's not going to be helpful to the client. And so again, using supervision to figure out who is the best person to service this client, right? And if your focus is on, I need to change the way they're thinking, then you really aren't the person for that client, right? Because you're not addressing, going back to the goals, and maybe it's because I come from Department of Mental Health, but it's like, what is the goal? What is the goal that you initially develop with the client? Right. And if you can't go back to that, then ultimately there's something happening. The countertransference is too strong. And you need to be able to figure out what are you going to do so that the client is able to focus on their objective and move throughout treatment.
Reminds me of our code of ethics, right? Like worth and dignity of every human being, even the ones that don't agree with us, in our values. It's finding worth in everyone, and trying to do it as, I mean, we're human, but as non-judgmentally as we can. I do want to make sure, because I don't want anybody to leave without feeling like, because I know everyone has either learned about liberation psychology or will be this semester or soon. I do want to just kind of end with, you know, is there any tips for how you can bring that into the room, as many of our clients might be feeling under attack right now, and the bigger system that impacts very personally their lives. And so I'm wondering if you have just any final tips on kind of integrating liberation psychology into practice.
Yeah, I think that for many of our clients who are in marginalized groups, there is this threat of annihilation, this sort of terror of affect, this feeling like I am going to be completely submerged in terms of my identity, my history, my culture, my language. And liberation psychology comes from sort of liberation theory that really begins to look at socio-political and begins to look at the concept of critical consciousness, to be critically aware of what's happening, the pathologies of power that are taking place, and for me be able to respond in such a way, not only alone, but with a group of people, to what is happening to me and the groups that I'm involved in. So that's the only thing that I would sort of make mention as they learn from FOAPE and or have learned from FOAPE is the ability to look at the client's life from a very socio-political perspective. History, liberation psychology is very critical of ahistorical, that there is no history to our client. And when you look at sort of Western psychologists, it was all intrapsychic and really beginning to look, and I think that's why social work is so beautiful. We look at them from a systems perspective. So that's just.
Yeah, and I would add that going beyond just what's happening in the room with your client and encouraging them to, I mean, if they bring it up, how can they be active in their communities, right? How can they either create a space or volunteer in a space that they feel heard, that they can be themselves, where they're not going to be questioned about their immigration status or who they are, but a place that really embraces them. And there's a lot of places that they can go to. And I think even for yourselves as therapists is finding those allies, finding those places where you can just deconstruct everything that's going on in your mind and then what's going on in society. Because I think when you're in this type of program, everything you knew before you came here has shifted. And so you're having to deal with that. And now all these other changes, and now you have your clients that are coming to you. And I do think that we hold a responsibility to open up the discussion and then, be that supportive system, but also outside of treatment, what are they gonna create outside of treatment? Because you're not gonna be there for them their entire lives.
Thank you. I want to be respectful of our panelists' time and also those who committed to be here. I know this is a lunch hour and some people might be thinking I have to get lunch before our next class. But is there anything else more online, Jason, that you want to bring in?
No, just a lot of great comments and I think a lot of appreciation as well for all of you and thank you, Rafael, Cynthia, Kim, Anne Marie for everything. But yes, we can definitely kind of wind down now. Yeah.
So just piggybacking on that, I want to thank you all for being here. It's it's a start of a discussion, right? These are discussions we have throughout our career and are essential to our growth and development always, not just as a student. So I really appreciate everyone being here and really our panelists for your insight, your experience, your wisdom. I always learn from you, so I really appreciate you making space to be here today. And also, Jason, I just want to acknowledge you and your leadership has been outstanding. So I really want to acknowledge all that you do in addition to go to school and your role as a leader. So thank you.
I'm walking in your footsteps. That's all. Just want to love to be a professor at USC like you. That's my dream. But with that, I also wanted to let everyone know that the recording will also be sent out to you for those who hopped in and hopped out, as well as, if you have any other concerns or questions, you could send them to us. We could maybe try to email you back. But again, thank you again so much for your participation. This was exactly what we wanted, really, an interactive workshop like this. And so I really just hope you as students and faculty and professors and amazing social workers, like, please know that you all are all amazing being here despite your work. So just know that we're all here to support you. So I really hope that you got some support today. Thank you, everyone. And thank you, panelists, everyone. Yeah. Have a good one. Have a good day.